It's great honor to be here. And before we start, I just want to thank everyone for the invitation and for the hospitality yesterday and today. You guys have all been fantastic, and it's been really nice to meet some of the residents and see the faculty and talk about the research and even meet some of the graduate students. You guys are doing an incredible amount of work, and it's you should be very, very proud of that. And I know that you are. I think in terms of like clinical productivity and academic mission, I found our institutions and our urology programs are actually quite similar, which really struck me because I think we should be collaborating more. And I'm hoping that some of the discussions that we had today, and maybe this will stimulate some thought for residents and fellows interested in transplantation or even in basic sciences research, to kind of get inspired, and hopefully we'll do some beautiful things together. And I think that it'll be up to Dr. Gleave and I to make sure that the interactions are created between some of our faculty and researchers at Western and UBC. So I'll take the next 30-40 minutes or so to talk about what we've been doing in my lab. We have been looking at the effect of small molecules in organ transplantation, and we'll do about 30-35 minutes, which opens up a lot of time for discussion, which is really the fun part of all this. Disclosures, no conflicts of interest with respect to what I'm going to talk about today, but I do have a lot of grants that are investigator initiated from a lot of organ perfusion companies, and I've started several companies, but we're not going to talk about any of that today. So I'm preaching kind of to the choir here. I mean, end-stage renal disease is a global concern, and we're all aware of that. 2010, about 2.6 million people had renal failure, and in 2030, we're expecting that to be doubled, which is quite staggering. And we're thinking more North American centric, but we have to think about the rest of the world where most of these people reside. And in North America, you can see that the numbers are on their way up. Unfortunately, as we know, kidney transplantation is the most optimal mode of
supply and demand. As the number of patients being listed for transplantation goes up, you can see that on the bottom right hand graph.
That's weird.
In the United States, this holds true for many.
Here you go. Yeah. That's weird, eh?
The number of transplants being
That's
done
weird.
never reached that.
Yeah, that's kind of odd. Yeah, that's very odd, eh? That's kind of weird. Is it recording? That's odd. Yeah.
And unfortunately,
so
this also
odd.
comes with a significant challenge, which is the one of supply and demand.
Okay, something about that slide.
Yeah, that's so odd. Okay. Anyway, thank you. That's good. So, very weird. So, in terms of, we think about transplantation and organ and kidney transplantation, what we need to do, it becomes a significant problem because we have a supply and demand issue, right? We have an increased number of patients being listed. We have over 100,000 people in US, another 5,000 in Canada, and that number's growing in a staggering amount. And as though as surgeons, we're trying to increase the number of living donors, deceased donors, et cetera, but we're really making a small dent in it. So I've been thinking about like technical solutions in terms of fixing this. Because as surgeons, I think we have to think about how do we pragmatically solve that problem. There's a lot of options here. There's moonshot projects. So you guys are involved in some of these moonshot projects, like universal blood group donor, removal of the A antigen with Dr. Guan's group. Thinking about bioartificial kidneys from UCSF, implantable dialysis machines. I think this is potentially going to be part of our future. The xenotransplantation that happened in New York, Alabama, and recently in Boston, that is likely going to impact how we think about transplantation. Expanding the living donor pool, we do that all the time. But what about lower hanging fruit, right? What about the things that we can control today? We have increasing number of marginal kidneys that we use. How do we make them work better? So let's think about those types of things. And that's what our lab has been focused on for many years. So one of the problems in transplantation and a lot of other things that we do in urology is ischemia, reperfusion, injury. And it's really unavoidable in kidney transplantation. I mean, the severity of the IRI depends on a lot of factors, like graft ischemic time, the quality of the donor, quality of the preservation solution. And then we know that has a lot of negative outcomes. So we know that there's higher rates of acute rejection, not primary non-function where the kidney doesn't work at all, delayed graft function, slow graft function, the list goes on. And unfortunately, these eventually lead to shortening the life of the graft. So the other thing we have to worry about is organ preservation. So in the old days, up to probably about 10 years ago, we were always on the left side of this. 0 to 10 degrees was the gold standard, and that's where things are at. But now we're thinking, is normothermic preservation better? The 35 to 37s. Or what about this kind of no man's land of subnormothermic preservation? What happens during that period? And we have to think about that. And you can imagine as the temperature goes up, the amount of resources goes up as well. And resources, not just manpower resources, but also financial resource to keep those organs alive. This is what we use right now for cold preservation. On the top is just an ice box, pretty low fidelity. It's actually surprising. That's what we still use since 1950s. And a hypothermic machine preservation machine. That's just one of them. There's several on the market. And then as you get more complicated, here's one of the other ones that you can do oxygenated machine perfusion at 37 degrees, but this is the size of a minivan. So it's not very, very useful. So our lab has been looking at overarching research questions. How do we fix this problem? One, could current organ preservation solutions be optimized? The ones we use are from 1950s. They haven't really changed. Patents have run out and other companies bought them out. They just make the same juice. Can we modify the juice? That's one. Two, what is the ideal temperature for preservation? Because right now, we've all, as transplant surgeons, we're training 4 degrees is it, but we realize 4 degrees really isn't 4. Kidneys come on ice. You've all probably been part of transplants where there's ice crystals formed on the surface of the kidney. There's a lot of damage that happens from that. The machines we use right now, they say 4 degrees, but you actually open up the machine and download the data, it ranges from -2 all the way to 10 degrees, but it says 4 on the outside. So that's a problem, right? So what is the ideal temperature for preserving organs? It has to be cost effective. It has to be resource light. Then the other thing is it has to be reproducible globally. I think we're so used to thinking in North America, what can we do at UBC and Western? Well, you can't do that in Africa. So we have to create a system that we can use everywhere. And that's kind of our goal in our lab. Yeah. I have a fellow from Nigeria. He's in the only transplant program. And they do about 20 a year. There's millions of people. Like, I mean, it's unbelievable. They don't have dialysis machines. So how do we help those people have better outcomes, right? So when thinking about these potential solutions, my PhD was in nitric oxide physiology. So we thought, well, what about some other small molecules? So we know that gasotransmitters are a family of molecules that have great cellular signaling properties. They're all made endogenously. We all make nitric oxide. We all make carbon monoxide. We all make hydrogen sulfide. And they all have vasodilatory and anti-inflammatory properties, but they have various amounts of protection in IRI, and they have double-edged sword qualities. So some of them, too much is bad, not enough is not enough. But during ischemic episodes, the right amount could be very, very helpful. So H2S is essentially colorless gas. It smells terrible. The lab smells like someone passed gas all the time. It's remarkably dissolvable in aqueous solution. It's formed from homocysteine and cysteine, and the reaction works in both directions. And we all make it all the time. And CBS and CSE, makes a lot. Does he? Okay. CBS and CSE are, I should come to the lab. CBS and CSE are the primary enzymes that we use in our bodies. Broccoli? I'm not sure broccoli releases sulfide. Yeah. Couple of the donor molecules. I mean, hydrogen sulfide is endogenously produced, but we can't give hydrogen sulfide as a gas. So there have been a lot of molecules on the market, from salts like sodium hydrogen sulfide to that GYY molecule that was kind of came out 10 years ago, 15 years ago. And then AP39 is more of a mitochondria-directed H2S donor, because we know that a lot of the protective effects happen within the mitochondria itself, and the triphenyl phosphonium motif gets it into the mitochondria, and it helps. So I'll show you some of the data that we have on those. We and others have looked at H2S and thought, how protective is this? And in the kidney, it's very protective. Through mechanisms you can see on the right-hand side, it has vasodilatory properties, it's anti-apoptotic, anti-inflammatory. It's an antioxidant and actually has mitochondrial protection, as I mentioned. And we've actually been using some of these angiogenic properties in some of the cancer models that we have, of bladder and prostate cancer. And it seems to work remarkably well. So our question was, can we use hydrogen sulfide and exploit its endogenous characteristics in organ transplantation to improve graft outcomes? As I mentioned to you, there's so many different variabilities. There's so much heterogeneity in transplantation. We want to hit all of them. First, we want to hit, does it work in hypothermic preservation in the ice bucket? Then we want to look at, does it work in subnormothermic preservation strategies and normothermic preservation strategies. And then lastly, can we think about ways to get this into the clinic? So I'll talk about the first one first. So Ian Law was an MD PhD student in my lab, and he went on to doing research. He's in Calgary now. So his study was looking at rats. So we took the rats and we created this model at Western where we take the kidneys out of the donor rat. We preserve them with either UW solution, which is the standard preservation solution, versus UW plus sodium hydrogen sulfide. And we did dose response studies in vitro to show that that was the dose. These kidneys were then preserved for 24 hours in cold storage, just like we do with human kidneys. And 24 in rat world is like 48 to 50 hours in the human world. So this is a pretty extreme storage duration. Then recipient rats underwent bilateral nephrectomy. Then they had the transplant kidney put into it. So this is a pure survival model. You are responsible, the kidney is responsible for survival. Animals went into a metabolic cages for 14 days and we measured various parameters. What we found, this is like 13 years ago. This is our very first paper. What we found was that in the presence of hydrogen sulfide, if we added H2S to the standard preservation solution, there's a marked improvement in survival. You can see it on the top there. And serum creatinine returned back towards control levels by a week, whereas the animals that are preserved in UW alone, which is kind of what we use every day in humans, they died actually by 5-6 days or so. When we looked at pathological indices, we have all of our pathology scored by independent pathologists. So we don't do any of our pathology. We send it in a blind fashion to downstairs to the nephro transplant pathology group, and they read our human samples and they read our animal samples. And so they give these back to us. So ATN, glomerular necrosis, and apoptosis all were reduced in the presence of hydrogen sulfide, and as were myeloperoxidase and neutrophil infiltration. So we know that inflammation. So we're really excited about this. But the next steps were, will it work on the pump? Because rats are very different from humans. Rats are very different from pigs. What about higher animals and higher mammals? And we know that many places use the perfusion pumps for organ preservation. So we decided to kind of embark on this, and we created a model which is very similar to the rats, but this time in pigs. So we did 1 hour of warm ischemia. So open up the pig, create a DCD model, donation after cardiac death model, where we clamp the pedicles and we take the kidneys out, one kidney out, preserve it for 24 hours with cold solution on pump, either with or without hydrogen sulfide. The next day you go back, you take the contralateral kidney out and you transplant the one you preserved and see what happens. And this one's done by Amira, who's a transplant surgeon. She was our first Saudi female transplant fellow, and she's leading the program in Jeddah now. So we're very, very proud of her. So what she showed was that flow rate on pump, in fact, increased, as you'd imagine, and resistance decreased in the presence of hydrogen sulfide. Now, in the transplant world, the pump parameters are extremely important. So when I put a kidney on pump, and I look at the resistive index, which is just a number that's generated based on flow and pressure, that number is very important. If the number is high, that tells you that you may have a problem with the graft, short and long term. And we've shown, presented at AUA last year, that if the rate of change in the resistance in the first 2 hours after you put it on pump has a big impact on delayed graft function and long-term graft function, which is really interesting. And so we saw immediately the resistance dropped in the presence of hydrogen sulfide, and we weren't really surprised because it's a vasodilator, but this was good to see. What was exciting to see, though, is that when we transplanted the animal with this kidney, you can see the UW group, which is the inverted triangles, the creatinine went up versus if hydrogen sulfide was present, creatinine actually was returning back towards control levels in 7 days. Very exciting. And it kind of held true with what we found in the rats. And we look at inflammatory markers. We found that interferon gamma, ICAM1, caspase-3 in terms of apoptosis, and BCL2 for anti-apoptotic markers, including ERK1/2. They all went in the direction that they were supposed to go. So I think this made us very confident that we're probably on the right track with this molecule. So as time went on, the world started to change. We started looking at other temperatures, right? We started looking at 37 and lower. So we wanted to see if this molecule was going to hold true in other temperatures. That's kind of what we went on to do in the next few years after that. Simi was a MD PhD student in the lab as well. She's at medical school right now in Calgary. interested in urology. So hopefully she'll come around here for electives. She wanted to look at what temperature is the right temperature. And so we initially started doing this in epithelial cells, kidney epithelial cells, pig kidney epithelial cells. And we preserve them in our machine. We have a hypoxia machine that you can modify both the oxygen tension as well as the temperature in our lab. And so we're able to look at 10, 21, and 37 degrees Celsius. And we coined the temperatures like subnormothermic preservation. And back then we knew about normothermic, but not about subnormothermic. So we thought, what about 21 degrees? Why 21? Well, wouldn't 21 be easy? 21 is room temperature. So we picked that number arbitrarily. Sarah Hosgood in Cambridge, they just published on 32 degrees because they initially thought 37 was key, but they're bringing the temperatures down too because 37 is so intensive. And I'll show you some of that data. But 21 seemed like an easy number. You get a kidney, you leave it on the desk, and then you put it in the next day. How awesome would that be? The temperature is for bypass. They do 32, 33. So that's why Hosgood's doing that 32 to 33 temperature. So what Simi showed was that temperature-wise, I think we were onto something. So you can see the data, UW group on the second from the left. If the temperature is 21 degrees, the cell viability is much higher than 37. So 37 actually didn't do great. If you added hydrogen sulfide to the mix, there was a dose-dependent increase in survival, which is great. We know that H2S is going to help with that. And then we went down to 10 degrees, and we found that 10 was actually better than 21. But when we did this, 10 was crazy. So we said, let's stick with 21 because no one's going to allow us to go to 10. They're already believing barely 37 in some of the clinical groups. Let's see if we can bring the temperature down. So Simi thought, let's start on at 21 degrees. So we created this ex vivo apparatus, which we have in the lab. I mean, it's a big collaborative effort to put this thing together. We have oxygenators from the cardiac guys. We have temperature controllers, blood flow and pressure monitors. The machine in the middle is a hypothermic machine pump. You can't get that in Canada. It's only available in the US and UK. It's the Waters pump. And you can see the kidneys there at the bottom. That's the pig kidneys connected. You cannulate the artery, you cannulate the vein, you cannulate the ureter. You can actually collect in, outs, and what comes out, right? So very expensive. It's about $10,000 per experiment because it's very labor intensive to keep these things going. So what she did was we wanted to use the same model, but see if we can actually test if the H2S worked. So that's one. And two, if 21 degrees was going to hold true in the animals as it did in the cells. So on the bottom is all of our controls. So you have static storage, which is 4 degrees Celsius. That was our standard of care. Pigs, again, went the DCD model, donated their kidneys. We put one on the other. We always match the kidneys. We used normothermic machine preservation, 37 degrees, because that was kind of the sexy going thing at the time. We preserved with blood, so non-stress blood donated from the pig. And we did also 21 degrees as our control. Then we did another group. The other kidney became the control plus the hydrogen sulfide donor molecule. And then again, the same type of thing. We look to see what happens over time. We reperfuse with blood. So these are storage in blood at warm at 21 degrees and reperfusion at 37 degrees with blood because it's completely ex vivo. And we're trying to re-simulate a transplantation. So what we found was that we can collect urine output during preservation. And we found that the urine output during preservation was actually highest if AP39 was available, which is the hydrogen sulfide donor molecule. But even without that, 21 degrees stored kidneys in blood made more urine than 37 degrees stored kidneys. So that was interesting. We didn't expect that. We thought 37 to be actually pretty good, but it wasn't. And then when we looked at reperfusion with blood, stress blood, we found that compared to the standard of care, which is 4 degrees Celsius, the 21 degree animals made more urine and they dumped less protein into the urine, which is a marker of the injury. Again, this is not a perfect model because it is ex vivo, but it gives us a little bit of a snapshot in terms of what's going on. And then looking at total urine output during the reperfusion phase, 37 degrees did not do as well as 21, but if you added hydrogen sulfide, it made it better. So it really helped us understand that potentially hydrogen sulfide at 21 degrees may be much better than 4 degrees and maybe 37 degrees. And our pathology held true for that as well. So it was an exciting finding, but I think it's very, very labor intensive. And to carry out this project, I mean, you have people spending the night in the lab, the graduate students are there, multiple students are there. We have a perfusionist there. They have to add insulin, they have to add glucose, they have to add antibiotics, they have to monitor lactate, fix the bicarb. Like, it is a ICU. So not everybody in the world can do that, right? And so should this be the standard of care? I don't think so, because it's too cost intensive. So my next graduate student, Maria, she was really interested in this data. And she said, I think there's legs here, but maybe we should bring the temperature down. We had that good data with 10 degrees. 37 is really intensive. 21's hard, but maybe 10 is easier. And at that time, there was some data that 10 degrees storage for lung, liver, and cardiac grafts was actually pretty good. But no one had looked at kidney before. So we said, let's look at kidney and see if that'll make a difference. And that was her question. So she, as all grad students, they start in vitro first, then they go in vivo. She created an in vitro model, again, confirming what Simi had shown before with various temperatures to see if hydrogen sulfide and storage at various temperatures would help. For her, though, what we did was we changed molecules because we realized, and I'll tell you a little bit of our clinical data afterwards, we realized that all the H2S donor molecules that we've been using to date, although they're working great, they have fantastic outcomes, very reproducible, we can't use them in humans. So we found an alternative, and sodium thiosulfate, and I'll talk a little bit more about that, was the alternative. So she thought, let me use sodium thiosulfate instead of the other markers. So the data is a little bit different than the one I showed you before with Simi's, which was using a commercially purchased hydrogen sulfide donor molecule. And so she found the same type of trends, though. She found that in terms of cell viability, 37 degrees didn't do as well. In fact, it had more apoptosis. But as you lowered the temperature to 10, you had increase in cell viability and a decrease in apoptosis. So that was one part of the story. The second part of the story, as I mentioned, is we're using blood to preserve these organs, right? To do ex vivo, any ex vivo testing done right now is always done with either human blood or animal blood. And one of the limitations to that, as we can all imagine as surgeons, is there's a huge limitation and a resource issue in terms of the availability of blood. In fact, in London, in my lab, buy blood from BC that's expired to use in our machines, so human blood, to use in our ex vivo discarded kidney models, because we don't have any in Ontario, but BC has a lot that's expired. So we buy them from BC. So we had to come up with an alternative to using blood. Yeah, it's because we use more blood in London because we're bleeding out more. I was thinking that too. Yeah. Yeah, that's right. I like that. I like that idea better. You guys are just better surgically here. I think that's why. But I think you should have more donors. I think that everybody loves trees and yeah, transfer. I like that. Maybe we should pay you back. So instead of going in the garbage, they come to our lab. So, but we had to come up with another solution, right? Because blood is great to test this. Because I mean, you think about the future where you get an organ, you're not happy, you're not sure if it's going to work or not. You put it on the machine. If it makes urine, it looks good, you can use it. And people have done that in Cambridge. And so if that's the model, blood maybe not be the right way. So we ran to this molecule, Hemopure. So Hemopure is a hemoglobin-based oxygen carrier. It's bovine derived. It's approved for use in humans. Holds the same amount of oxygen as a human hemoglobin in a tetramer form, and it releases oxygen more readily. And the oxygen dissociation curve is very similar to hemoglobin, but shifted over a little bit. So it's actually really good in ischemic periods. So I contacted the company. Zaf is their CEO, and he was trying to get funding. He bought the company from a Russian company, and he had tons of this Hemopure stuff that he was giving to hospitals in the US for compassionate reasons. He was giving it to the military to use in war field, because you don't have to type anybody, just give the Hemopure. It works great. But I said, I want to do this in research. So he was kind enough. He gave us liters and hundreds of liters of the stuff to allow us to do these experiments. So he was very kind in doing that. And we said, well, so let's compare. Let's do a head-to-head hemopure storage and preservation versus blood preservation, do we get the same answer? We got the same answer. So and we published that. So that now allows anyone to do this type of research without using blood. So they can get hemopure. And ZAF just got funding. They raised $60 million. So they're going to start a facility in New York. So now hemopure will be available commercially, which is great. So if you guys want to get into it, he'll send you some stuff. There's another company out of Paris. I just talked to them last week, Hemarina. They just got onto the market, and they are making a similar product out of sea slugs. And so we're going to start some research with them, but it's the same type of thing. And I think this could be the future of transfusion medicine. So it's really, really cool. But so kind of going to the experiment. So in order to get a 10-degree setup, we had to create a new pump because the existing pump, which you see on the right-hand side, wouldn't accommodate the 10-degree and it's too cumbersome. Again, we're trying to make this usable everywhere. So contacted Bridge to Life. They're kind enough to give us one of their VitaSmart machines. We took it apart and added our own circuit to it to see if we can get it to work at 10 degrees. And it does. You just have to kill some of the alarms and stuff, but it works. And so it's really nice. It's good to have these types of relationships with companies. And I think that is something that is, we are fortunate in urology that we have access to so many cool technologies. It doesn't matter what urology specialty you're in, we have access across the group. But these companies are also very willing to allow you to use their equipment to do novel things because they think that's probably going to be the future. So I don't think it hurts to ask. So if you ever have a thought and you think, you know what, I would love to modify the scope, I'd love to do this, you'd be surprised how malleable they are in terms of allowing that to happen. So just a plug for that. I mean, these transplant companies have been very, very kind. So what we did was we had to make sure that we take our Hemopure and we had to take it. It's very expensive and there's not enough of it around. So we thought, do we need to use it straight up? Do we need to dilute it? What's the dilution with UW? Because UW is very cheap in organ preservation. And how do we oxygenate it? So I want to make it easy for everyone to use. So we did a 50-50 dilution and a 25-75 dilution. Because again, we're trying to preserve Hemopure. And we pre-oxygenated it ahead of time, a liter a minute for 10 minutes. And then we put it into vials and to see if the vial would hold oxygen. And so here's our, you can see over a 24-hour period, we got 10 degrees Celsius, it doesn't change. And you can see on the bottom, the oxygen tension, whether you use 50% Hemopure or 25% Hemopure, you ended up with a decline by 6 hours, but by 24 hours, you still had the same concentration of oxygen. The partial pressure of oxygen in the vial did not change. So that's not biological, nothing's using it, it's just sitting in a closed vial, but at least allowed us to know that the dilution factor didn't make any difference whatsoever because the dissociation curve is so good. So then we said, okay, let's go back to our animal experiments and let's see if this works. So Maria took, we have microsurgeons, but Maria helps. We did native nephrectomy, right, on the recipient, did a donor kidney, same model, one kidney went to one place, one kidney went to the other place. We preserved these kidneys in static solution. So that's kind of the limitation here. We preserved them in static solution at 10 degrees Celsius in pre-oxygenated Hemopure/UW solution with and without our hydrogen sulfide compound. And we saw what happened. So here's our survival data. It's not great. I mean, all the curves look kind of the same. Statistically, they're barely different, but I would say not, okay? But we saw a definite signal with the top, the Hemopure plus UW plus STS. The survival, there was a distinct survival advantage, but not in this model. And the reason is because we're actually expecting oxygen to travel, and this hydrogen sulfide to travel by osmosis and diffusion from the vessel into the renal parenchyma, because it's not being pumped like it is on a pump. So we're going to redo all these in pulse-type perfusion. I think that's going to make a difference. But what we found was interesting in terms of your biomedical profile, there was a difference. We found that creatinine, serum creatinine was better, BUN was better, GFR was also better in the presence of Hemopure storage at 10 degrees Celsius in the presence of hydrogen sulfide. So I think at least it allowed us to want to go forward with this. And when we look at pathology again, we found there was a reduction in apoptosis and necrosis in the Hemopure and hydrogen sulfide preserved organs after transplantation. as the reduction in neutrophil infiltration and macrophage infiltration. And all those are very important in terms of the early signals of inflammation, which then recruit the T cell responses in transplantation. So I think this is very, very positive, but we do see the limitations here because of the lack of perfusion. Then we want to look at KIM1, which is a marker of tubular damage. That was also reduced in those animals. So in the end, Maria's conclusions were that preserving rat kidneys at 10 degrees Celsius, especially with hemopure and sodium thiosulfate, could reduce tissue injury, at least in this early model of graft function. And it really helped add to that literature in the world that not only lungs and livers and cardiac grafts can be preserved at 10, but maybe kidneys can be preserved at 10 too in the right environment. And then we could reduce that 4 degrees Celsius issue in terms of organ preservation. Maybe this could help with future transplants. So our proposed model may actually be the simplest way to and cost-effective way to do this. And it's very simple, very low manpower issues, and cost was quite negligible. So I think this may have some legs. So that's very exciting. But I think as clinicians, we want to know, does this work in humans, right? And I think that would be my question. So that was our next steps. So, but hydrogen sulfide, is it ready for prime time? I mean, I talked a little bit about this before. We know, I mean, I don't have to tell you that there's protective effects here. I think we've done 10 years of research that it shows that it does. I don't think we need to beat it anymore. But the molecules we're using have always been either made for us by collaborators. They're distinct donors of hydrogen sulfide, or things we bought from BWR and all these companies. But they're not going to go through FDA and Health Canada clearance. It's going to take years. It's going to take millions of dollars to get that through. So are there alternatives? And that's where we had stumbled upon that sodium thiosulfate I mentioned to you before. It's an FDA-approved drug. We use it all the time in kidney transplant and renal failure patients. We give it for calciphylaxis. If you go to the Emerge because you had cyanide, they're going to give you sodium thiosulfate. You go downstairs, they probably have millions of vials of this stuff. It costs $10. It's free. It's derived from the metabolism of hydrogen sulfide. So we said, you know what? This could be it. Like, why are we beating the doors of all these molecules that work great? What if this works the same? So we did some studies, and others have started to do this as well. Does it have the same properties as our other hydrogen sulfide molecules? And it does. It has antibiotic properties, antioxidant properties, and it's been shown in brain ischemia to be very helpful. And it does do the same thing as hydrogen sulfide. The way hydrogen sulfide works is that in ischemia, we all remember kind of the mitochondria electron transport chain. You can't make ATP in hypoxia. But what happens is the sulfide donates electrons. So you make ATP in a very inefficient manner. So you are still making ATP in the fridge, which you shouldn't, right? So in the presence of hydrogen sulfide. And we've shown that, others have shown that. So that was very exciting, that it kind of did the same thing as the other molecules. So Max was my grad student.
Can I ask a question about that? Just go back.
Yeah, sure.
What I don't understand there is that it downregulates pro-apoptotic molecule. BCL2 is anti-apoptotic.
Yes. So upregulates BCL2.
Okay, but it does downregulate.
That's upregulates.
Okay.
Upregulates BCL2. Thanks for catching that one. So Max, my graduate student, he said, "Well, I want to look into this thing with STS." So he's now in California, and so he did the same model again. UW STS. The dose is 150 micromolar. And we did that through a series of studies, dose response studies, to see what the optimal dose for sodium thiosulfate would be that would give you the same in vitro response as the AP39, which is our tried and true hydrogen sulfide donor molecule. And we did the same thing, donor rats, nephrectomized recipients, and transplants. And we had a sham group, and we did the same 14-day trial. And what we found is exactly what we found with AP39. The survival curve at the very top is what you get if you preserve a kidney in sodium thiosulfate. You preserve it for 24 hours in the fridge, and you transplant it, and you get way better than using UW solution, which is what you used yesterday, right? Okay, right? So we use it every time. And so it's incredible that it makes that much of a difference. The creatinine got better. The UN got better, not as fast as the AP39. It's a different molecule, but it's pretty close. You get a trend towards controls. When you look at kidneys function, we saw that osmolality and urine output definitely worked. I mean, the kidney it loses its gradients when it has significant ischemia reperfusion injury. And eventually, as you can see in the STS group, the urine osmolality goes up towards control, so it's becoming more concentrated. And the urine output goes down, so it's not diuresing as much anymore. And our pathology data held true as well. Tunnel, apoptosis, and necrosis all were reduced in this. So we're confident that this is likely going to work, and Kim 1 did the same thing. Neutrophils and macrophages are tried and true for transplant. Again, follow the same thing. So I think we're very happy that this could be clinically viable. So based on all this 15 years of data, we said, someone's got to jump. So we called our hospital ethics board and said, listen, we want to do this in humans. We have 15 years of data that is solid. We applied to Health Canada. Health Canada said, go, you can do it. So we went ahead. So we've done 20 transplants in London with our own hydrogen sulfide donor molecule mixed into standard UW solution. This is George. He's my postdoc in the lab, and Clarice. They've been great about getting the study going. So we randomized patients into two groups. We initially started with the donation after cardiac death group because they were the group with the most damage to the kidneys. And they're the ones that were likely going to see a signal if this worked. We used the same dose that we did in pigs and rats, so we didn't change the dose, and that was the agreement with Health Canada. We randomized them at the time that they came to the hospital. I'm showing you the first five, N of 5 in each group. We got unblinded as for our CIHR grant that we just recently got. And what we looked at was over a 1 year period. What we found is that the urine output in the first week after transplant was higher if the organs were preserved in sodium thiosulfate. Urine protein excretion the first week was also lower. Okay, so that's only N of 5. Creatinine over time, it's a DCD kidney. They don't get great creatinines at the beginning. We're high as like 500-600s in both groups. The thiosulfate group was slightly lower, statistic not significant. N of 5, we didn't expect any statistics at this point. And when we looked at the resistance, we talked about how fast the resistance changes on pump, and that slope is really important. In the presence of H2S in UW, the slope of the resistance curve was much quicker. So we could predict that it's going to have a much better long-term outcome. So very excited about this. And when you look at the two groups, they're actually age-matched. Warm time is matched. In fact, the sodium thiosulfate group had longer cold ischemia times. I'm not sure what the cold times are like here at Vancouver, but our cold times can range between 8 to 20, 30, 20, 25 hours. So they were pretty short. But at least as a proof of principle, it showed us that this definitely could have legs. So very, very excited about this. And we're going to continue with that. And we're hoping that we'll do a multi-center trial. And we've got other groups involved, and hoping that UBC will be part of that as well. So my student right now, Pierce, who just got into UBC Med School, and he's really interested in urology, he told me yesterday. So he's very interested in urology. And so he is going to come, or you'll probably see this face. He's a OHL goalie, actually. He's a great guy. So he thought, well, all this stuff for treating organs in the box, but what if we gave it to the donor? Is that legal? Is that possible? I mean, there's an ethical issue here, but what if you could pre-treat the donor so you have a better outcome long-term? I mean, you could, in fact, some of our urology patients, let's say you do a clamp for a big tumor. Could it help if you gave sodium thiosulfate to the patient before you clamp their kidney? Whether it's 20 minutes, 30 minutes, if you do it off clamp, it doesn't matter, but could it make a difference? And so he wanted to look at that. And there's some data out there from Boss's group from early 2010s that after transplantation, the kidneys that did better had higher levels of the CSC, which is the enzyme that produces hydrogen sulfide. So it's a bit of a stretch, but is higher hydrogen sulfide helpful in those kidneys? And that's kind of how we framed it. And we said, let's go ahead and do it. And there's a study actually, just on hold right now, from McMaster, where it's a synergy pilot trial. They were giving tacrolimus, which is the immunosuppressive medication, to donors before donation. So these are people in the ICU. So that got approved by Health Canada. In fact, we have a Canada-wide transplant research consortium for clinical trials. We're trying to get these types of trials becoming accepted across the group. And one of the reasons why this trial is on hold now is they actually had good data. But the problem is you're not just procuring kidneys. You're procuring lungs and heart and liver and pancreas, intestine, eyes, joints, and all this stuff, right? And so, yes, the kidney people are happy, liver people are happy, but maybe the panc people are not sold yet on the tacrolimus. And maybe the lung people are not, and the heart people are not. So that's why the trial is on hold until we can get agreement amongst all of our organ groups and say, like, this should be beneficial to everybody. But there is precedence to do this. So that was Pierce's hypothesis. So he went ahead and he did the same type of experiment. And in order to get the tissue concentration right of the sodium thiosulfate, we couldn't give it as the dose that we use in preservation grafts because that's in a closed system. We actually had to dose it based on volume to get the same concentration. So 2.4 milligrams per kilogram in the rats comes to about 150 micromolar concentration in the bloodstream. So 30 minutes before organ donation, tail vein injection of the sodium thiosulfate, and then the same process as I mentioned. Kidneys come out, store for 24 hours, get transplanted back. And what he found, and he's just wrapping this up, the signal wasn't as great. I think we're a bit off here. Although there is an improvement, statistically, this is not going to come out to be significant. We can see that the survival is better in the combo group, so sodium thiosulfate pre and post, and maybe a little bit with the pre. And by, pathology looks good, but survival does not. So either the model isn't working, either our dose is not working, or something's not right, or we're barking up the wrong tree. But there's a bit of a signal here, which is very, very exciting because it does look at does pre-treatment using others, it doesn't have to be sodium thiosulfate, it could be other things. Could that be helpful in the long term? And our tunnel assay suggests that as well as our neutrophil infiltration. So pre-treatment of donors, is it possible? Yes. Do we get a bit of a signal? Yes, in some parameters, maybe not survival yet. Maybe the model's not perfect, but I think there's definitely some legs there, and we're going to keep pursuing this in the lab. But potential applications are huge because, normothermic regional perfusion, it's like using the ECMO machine in a donor in a DCD. We did the first ones in Canada, or we did 4 already. We did liver and 2 livers and 2 kidneys in London, and then Toronto did one. And hopefully, I understand you guys are going to have somebody come out here to talk about NRP. NRP is the future, I think, in organ donation, especially for DCDs. And it is going to revolutionize the outcome of these grafts. And so speaking to our NRP docs, we're thinking of adding the hydrogen sulfide donor molecules directly into the ECMO type machine while we're procuring the organs, because that could make an impact. The other thing is living donation. Sometimes we get living donors where the graft doesn't work. It's got slow graft function because pre-treatment affect those. And obviously ICU intervention is another one. And that's something that we have to go through with the whole consortium. So we're very happy about these so far. So overall, hopefully, I think I've hopefully been able to convince you that adding hydrogen sulfide can lead to protection in cold ischemia reperfusion injury, in clinically applicable models of kidney transplantation, whether they're rats, pigs, or ex vivo. Appears to be also protective in DCD models, which is great. It seems to work at subnormothermic temperatures, which is excellent, 10 degrees, 21 degrees. And STS may be a clinically viable solution. So we don't need to try to get other drugs through FDA or Health Canada because STS may be all we need. So really in the future, is it possible that it could be helping us with organ graft outcomes? Definitely possible. It's cost effective, it's cheap, and could impact the supply demand part of the equation. So where do we go from here? I think STS and human trials, that is our next goal. We're starting that study back up again. Talked to obviously us, McMaster's interested, U of A, Ottawa. I'd love it if UBC was going to be part of that trial. We'll send you everything, all the ethics, RB, and you can discuss it and see if you want to be part of that. But I think that will really make an impact and really helps with pushing Canadian transplantation forward, because we are in Canada, we are a force as urologists. And I think in transplantation, I think we need to keep that flag going. Our US colleagues are in fact looking to us sometimes to help with some of these studies, because the US system in urology is somewhat fragmented in terms of transplantation. We also want to look at head-to-head ex vivo trials. We talked about different temperatures, but we don't really know. We've used so many different models. I want to see what's the right temperature, 4, 10, 21, 37. We can use human discarded grafts with blood from BC. We can use porcine transplant models. We can do those. Or we can use our HemoPure. And then we talked yesterday about modulation of the gut which we're doing right now, and urinary microbiome, which you guys are doing, I think that's got great legs, and we should definitely collaborate on that, because I think that is it's going to help in transplantation. And the other thing we're working with you guys is removal of the blood group antigen, right? The removal of A antigen, making universal organs. That is key, and I think that that has huge legs, and I'm really proud to be part of that work, because I think as urologists, pushing transplant forward, and working as a team, because I think everyone has so many different expertise, and just by being here, I realized the synergy that's there. We should definitely learn from each other, and push these things forward to lead transplantation and urology across the board. So where do we see this in the future? I think we're going to get grafts from all types. In 1950s, 54, when we were doing kidney transplants, they were the healthiest donors possible. Outcomes were better. I'm not surprised, right? But now they're not. We're taking 78, 85-year-old donors with diabetes and hypertension, have Hep C. Like, that's going to give you a different outcome than 1954 identical twins. So I think we have to, and people aren't getting younger. They're getting older. They're getting sicker. Precision medicine, AI, everybody's going to live to be 120. So, but this is not going to go away. So we have to look at how to make better use of the organs that we have until new technologies come, right? So this still has a lot of time for improvement. So do we think about donor pretreatment? Do we think about looking at the organ quality in an NRP setting, ex vivo setting? Definitely possible. And then do we preserve these organs afterwards? How do we preserve them? How long do we preserve them? And during that preservation, with and without, like, for example, we're hydrogen sulfide biased, but there's other molecules out there. Is it a combination of molecules? That's why I think working together is key. And then could we improve the outcomes of these marginal kidneys? And maybe other groups who are really good at gene therapies, could they be involved with these groups so they can modify the graft while it's being preserved on NRP or ex vivo before we transplant? And I think that really, really is the future. All the stuff, team effort, obviously I wear many hats, and I think without these people, none of this would happen. This is from our lab party last summer. I think I'm indebted to everybody here and some of the other students that are not listed, who've gone through the lab, who've helped the journey along. And it's really special to be part of their research journey as well. So I'm thankful and grateful that they were with us. And obviously we can't do this without money. So thank you to our partners. Thank you.